All right, this next chapter, just to tell you how much involved it is, and you can actually take a whole semester of just talking about this disease. Okay, so it's just kind of unfair to have to cover in one chapter. Okay, but I'll just do the best I can for what we have. It's a limited amount of time to teach this stuff. So just really, you want to get the basics down. Okay. For infectious diseases, there's many different kinds of infections that you can be attacked by, and your patients be attacked by. It can be from bacterial, viral, to fungal. And there's even something here that's not even here, which is called prion disease, which is just a protein band that can actually attack an individual. Prion disease is Creutzfeldt-Jacobs disease, CK disease, or what's called mad cow disease. Okay? So these are rare, but are potential problems that you may hear about. Okay? As long as you're not eating brain tissue, you're okay. And prion disease is caused in the old days. Where it was first discovered was back in New Guinea, where people were cannibalistically eating other people, and the people that are actually getting it were not the men, but the women, because the women would make pudding from the brain, and they would feed the little kids, and they fed the other women with it. The men didn't eat brain; it was considered not so good. So, as for how did our cows get this disease process? Okay, well, what they do is for cow feed. I mean, a cow is vegetarian, right? I mean, imagine what we do to their poor cow. We take lamb or diseased animals, and we just crush them up, and then we make feed for the cows with it. So the poor cow is being fed brains of another animal. So that's why they developed CK disease. And of course, the animals that were getting sick are the ones they were disposing of this way, and then they're feeding it to the cows. So you wonder why the cows got sick. Okay, cows shouldn't eat meat. Okay, it's just one of those things, but it's what you see. Okay. Now, as for the rest of the diseases, these are things that are more common. Bacterial diseases have been only known for about 200 years. It wasn't till we knew about electron microscopy that we even discovered viral diseases. Before that, we just called them all germs. So in the early 1913 or 1912 was when we first discovered viruses. The first virus that we could actually see was smallpox. And it still is the only visible virus under microscopy. Okay, so that's why they'll never get rid of it. There's still reference labs here in the United States as well as in Russia that have smallpox, and they are playing with it constantly because they can actually, put stuff in it, visualize it under a microscope, and see what it has effect on the animals that are exposed to it. Okay, of course, hopefully they'll never get out. Anyways, the next one is fungal diseases, and that includes molds and yeast. And fungal diseases are usually not a problem for us most of the time unless you're immunosuppressed. And what we saw initially back in the 1950s, 1960s, when we started doing transplantation and then finding out that we could immunosuppress people, we started finding all these kind of rare mold diseases and fungal infections that occurred from the immunosuppression. Okay? What really helped us was in the 1980s and 1970s with HIV to help diagnose it, because we found that it was an immunocompromising disease. When you look at bacteria, they can be labeled either gram-positive or gram-negative. Okay? Gram-positive bacteria have a slightly different cell structure in comparison to the gram-negatives. Okay? Gram-negatives tend to be organisms that you find in your GI tract. Gram-positives tend to be found on your skin. Okay? The differences in the gram-negative is sometimes they're flagellated organisms. They both have that, but they have a more of a thicker layer with the gram-negative, which makes it a little bit more resistant to pH changes in comparison to the gram-positives. That's why you tend to find it in the GI tract more so. You can actually differentiate the actual wall itself by the way the actual makeup of it is. And they're now using it in reference labs to actually identify the bacteria that you're playing with. Okay? In the old days, you used to have to put it on a plate, and you had to sit for 2 or 3 days to get the information back. But now with PCR technology and different things, we can actually identify individual components of the cell wall and begin to identify the actual organism. So things are getting a little bit more rapid into being able to identify things. Gram-positive infections, things like strep pneumoniae, okay, or streptococcus, can be very lethal to individuals. Okay, as you can see, this is what it looks like in the blood agar plate. Okay, that's why it's red. It's made out of blood. Bacteria seem to be very happy living off that stuff. What you get is bad infections such as skin infections, and if you get into deeper structures, of course, it can cause damage to many different kinds of cells. Oops. Gram-positive infections that are specifically found are things like strep pneumoniae and strep throat. You can see here, this is a person with strep throat. You see the pustular lesions on the tonsillar bed. You're going to be intubating people, so you've got to be able to identify these structures as you go in. Okay? If you look at the airway, this is the uvula. Okay? Okay? This is a little hanging thing down here. Okay? That's a uvula. Okay? Right next to it is what's called the anterior pillars, which goes all the way around here. That's what the front door to the pharynx. Then you have the tonsils here, and then behind that you have the posterior pillars. So the tonsillar bed is between two posts. We call them the pillars. Okay? And the surgeon cuts out these tonsils by staying within those two structures. If you go too far this way, if you're over here, guess what runs right in there? Carotid artery. Okay, so you can see that every once in a while a surgeon will actually cut into the carotid artery. I've seen that happen with a kid. It was a disaster, to say the least. But you know, something you have to worry about too. So things that will cause problems with strep infections, you'll get skin infections, you'll get impetigo, pyoderma, cellulitis, and irisalas. You get sinusitis, otitis, all these things that can cause by the actual streptococcal infections. It's also strep. It tends to be associated with OB. It used to be called what's called puerperal fever. Okay, what puerperal fever was in the old days was in the 1800s. The doctors didn't wash their hands. They would actually go and take care of women after they did an autopsy of somebody, and they wouldn't even wash their hands. The way you knew how good a doctor was was looking at their coat. They had so much pus on the coat that you could stand up the coat without having to put it on any kind of rack. That guy was a good doctor because he was taking care of a lot of people with bad infections. Okay? What he was doing basically, he was basically a big, huge pus infection that touches you. Now the woman would die of puerperal fever. They were actually developing streptococcal infections. The mortality rate in this hospital, I think it was in Vienna, was 10 times higher in the doctor's ward than in the nursing ward. The nursing ward wasn't allowed to do any kind of autopsies, so the doctors were the ones that were killing the patients inadvertently. So that's called puerperal fever, so it's streptococcal in nature. Impetigo, you can see the skin begins to degrade very quickly. It can actually cause a sloughing effect. This is very concerning to you, and that means that you need immediate IV antibiotics for these individuals. These pustules are infectious. They have streptococcus all over it, so you got to be careful if you're managing these patients that you don't become infected yourself. This is the kind of case where you don't want to scratch your eye or you scratch your face while you're doing these cases, as you may get infected as well. This is a irisella. You can see the skin begins to break down. This is a chronic infection you're seeing in this individual as well. Sometimes difficult to treat, and usually it's indicated by low perfusion states of this person's skin. A lot of times you see these people are diabetics or have some other kind of secondary disease where they're immunosuppressed. Then you have the worst one, which is pyoderma gangrenosa, which is the actual skin begins to slough off. And when you open up the skin, you'll see it drain with fluid that looks plasma-like. Okay? That's what's called fluctuant pus. In the old days, when you actually talk to physicians and you read the old textbooks of the 1800s, they would describe pus in many different ways. Okay? They would describe it as fluctuant versus sanguineous versus it was purulent. And that quality was because of the different organisms that were attacking it. Once you see somebody with specifically a green pus infection, and you can smell it. It smells like yeast. It smells like bread dough. Is actually, what disease is that? Pseudomonas aeruginosa. Pseudomonas, once the first time you smell it, you'll never forget it. Okay? It smells like fresh bread dough. Okay? And that's not a good sign. And that's a difficult one to treat. But this is pyoderma gangrenosum, which is due to some strep. Some of these are associated with flesh-eating bacteria, which is more staph-related, but they can cause very similar problems as well. Group A strep infections are what are called the non-suppurative sequela, are things that are the antibodies begin to form against the cellular wall, okay? And these antibodies begin to produce what's called a cross reaction to the host autoantigen, so it becomes an autoimmune activation. This is a person that develops rheumatic fever. Okay, rheumatic fever is an autoimmune attack of the heart valves that can cause a problem and then not present for about 20 years. You can also develop a much more acute onset where you get acute renal failure from what's called post-streptococcal glomerulonephritis, which is glomerular basement membrane is actually attacked by the antibodies, and you start seeing that you start punching holes all over the kidney nephron and cause problems. Now let's go on to gram-positive infections that are different than streps. Now we're looking at staph. Strep and staph are both gram-positives. Okay, staph is much more concerning because there's all sorts of bad forms of staph. There's VRSA, which I personally hate. I've seen a whole unit be wiped out by it, which is vanco-resistant Staph aureus. Okay, MRSA is methicillin-resistant Staph aureus, but it still responds to vanco. Okay, but VRSA is a nightmare. Okay, it kills the whole unit very quickly because most of the time people pass it down for the next patient to the next. Staph also has kind of interesting infection because it can also cause a toxic shock syndrome, which it releases the actual exotoxin in the individual, and if you can't identify the source, basically the person dies on you without even with treatment of antibiotics, because it's not the bacteria itself that's causing the problem, it's the exotoxin that is producing that's causing the problem. So even if you're killing the bacteria, unless you're killing the actual source, that's where you're going to get into trouble. Usually what you're looking for TSS is usually a retained tampon or some kind of foreign body that's in the individual. The other place where you think about TSS is a gunshot wound, where somebody has been shot with clothes. The clothes becomes embedded, and sometimes the clothes has already staph on it. Bad luck for that individual. Sometimes it can be difficult to treat, as you can imagine. The Staph aureus is the one that tends to cause very much skin infections that we see, which is furuncles or carbuncle, the things that people see in people's faces. As for the epidermidis, it tends to be more benign most of the time, and it's pretty much considered okay, except every once in a while it becomes an opportunistic pathogen in immunocompromised individuals. So anybody who has immunosuppression, epidermidis could be a problem. But under normal circumstances, when you get that back, you're thinking, that's going to be okay. Most epidermidis are pretty sensitive to almost all the antibiotics that we hit them with, so usually it's not a problem. Staph, the actual virulence actually can be changed. Staph is kind of nasty in the sense that it actually can change its actual matrix a little bit and make itself a little bit more difficult to treat, all the way to becoming vancomycin resistant. MRSA is a common risk for acquiring MRSA is that the patients are hospitalized, have been in the hospital for prolonged periods of time. If they've been multiply hospitalized, if they're greater than the age of 65, because as you get older, immunosuppression begins to set in. If the person has invasive drains or catheters, if they have any kind of open wound, if they have severe underlying disease, especially like long-standing diabetes, which immunosuppresses you. If the patient's on multiple broad-spectrum antibiotics, you knock out your normal flora, you end up replacing it with MRSA. If you're around people with MRSA, of course, and what's really scary about MRSA is that it's really preventable. And it's sad that we have it around. In Europe, they got rid of it in certain countries. They completely wiped it out. If you go to most American hospitals, it's an epidemic. Okay? And we're not treating it appropriately. We're not doing what's necessary. Okay? And you'll see it. I mean, when you get to clinical people with MRSA come in, they don't even tell us. Okay? We're not even told the person has MRSA. So now we're touching this individual, and now we have this stuff all over our hands. It's just ridiculous. Versus now they're finally starting to do more of, testing on everybody to make sure that if they walk into the OR, we know ahead of time that they have MRSA. Unless the communities and the physicians and nurses are really interested in getting rid of this stuff, you're not going to. You have to change the way you do things to stop it. And it's sad that as much as we know, we can basically stop this, but we don't. You can see in Europe, though, like in Scandinavia, they have got zero MRSA. They actually eradicated it. They actually went to the nursing homes and attacked it from that point of view and basically removed it out of their environment completely. And as a consequence, they don't have it as a problem anymore. Things that are really crazy, though, if you think about it, MRSA is found a lot now in fields, in football and soccer fields. And you ask yourself, why? Why would MRSA be all over the place? Because when you're actually taking water and you're using the water to water the fields, and it's basically non-potable water, what does it have in it? You can't drink it, right? You see it everywhere or it says on the don't drink this water. Okay? And the reason it's not processed properly. So antibiotics are in that water from people that have defecated it from upstream, from when you go to the stool. When you go into the bathroom and you have the bowel movement, okay, if you're taking antibiotics, that antibiotic is flushed into the system. That gets into the water supply. And then the water supply that you irrigate with has antibiotics. So what do you kill? You kill all the highly sensitive bacteria, and what you're left with in that field is highly resistant organisms, which include MRSA. So when a student comes in and gets scratched on their arm, they develop MRSA infections. Okay? So just be aware of that. If you have kids that are playing in the football fields, make sure that they're not using that kind of water. I think it's criminal that they're doing that, but again, personal discussion. Carbuncle, okay, is an elevation, and you have pustulence inside of it. So what you have to do with all these diseases is that you've got to drain them, okay? But you don't want to drain them by causing it to spread beyond that. If you can treat it with antibiotics, better. Sometimes skin antibiotics will work, but draining them ultimately for surgically, we do this often enough. So we want to drain these opens, and let the pus come out. That way you can decrease the actual bacterial count, and then you treat the person with IV antibiotics. Things that you also will see is paronychia, which is right here. This is a staph infection. This person has it. Guess what? If he touches a patient, what's he going to do? He's going to infect that individual. So it's another thing you see. Always make sure your hands are always clean. Make sure your hands don't have any breakdown in them. Do not trust gloves. Okay? If you trust gloves that keep you from becoming infected, you're a fool. Okay? 15 to 30% of the gloves are penetrated when they sell it to you. Okay? 1% to less than 1% of surgical gloves have little holes in them. Okay? So if you think that your little glove box is going to keep you from becoming infected, you're wrong. Okay? You need to be careful and need to avoid people with infections as much as possible and wash your hands frequently. You get scalded skin syndrome. You can see how severe this disease process is. Okay? And then you can actually, which we don't have pictures of it, will actually cause necrosing of the muscle as well. I've seen some very nasty forms of staph that do that, and it kills these individuals pretty quick. The gram-negative bacterial wall is a little bit thicker. It has more polysaccharide components. It makes it a little bit more resistant to changes in pH. It's got this like protective layer in it, which makes it more likely to be found inside the GI tract of animals. So gram-positives tend to be on the skin because they're very sensitive to alterations in pH. But gram-negative organisms tend to be found inside the animal. If you actually gut an animal anytime, and one of the things you want to avoid, of course, is penetrating the GI tract, the entrails, because that will expose the meat to this gram-negative, and if you eat it, you can become very, very ill. Gram-negatives can cause many things to happen. It can cause a cell wall, can cause like an endotoxin release, but they can also cause, when they break down, activation of complement. They can hyperactivate clotting, inducing what's called the DIC phenomena. Some of them can actually also cause mast cell degranulation and endothelial cell activation where they increase the permeability. And you get what's called shock states from these individuals. You can get into very nasty forms of shock. You can go from cold to warm shock. We've talked about that before. But there's different forms of bacteria or gram-negatives that specifically are more likely to induce shock-like states. Gram-negative, the most common one you think about is E. coli, which is prevalent in everybody's stool in very high amounts. Okay? What's really cool about E. coli now is we can identify their lipo layer by a PCR, so you can actually identify what kind of E. coli you're dealing with. Okay? And you'll usually see they'll say E. coli 123 or 115 or whatever it is. They number it by. Some of them are pathogenic, and other ones are basically benign. And you can see that E. coli is, people think about, it's not a big deal. It is a big deal. It actually kills a lot of people from diarrheal diseases, and it can also cause very severe forms of nausea and vomiting in people that ingest this material. So E. coli rapidly grows in certain environments and does very, very well. So gram-negative, as a consequence, you see it's red on your stain. The other things that also are gram-negatives are things like salmonella. Salmonella is found in many reptiles. Okay, so if you have a snake, you got to be careful touching them. Okay, if you're into going into the zoo and you touch a snake, make sure you wash your hands afterwards because you may now have salmonella on your skin. They can form severe forms of gastroenteritis and diarrhea. In South America and Central America, you're more likely to develop what's called typhoid fever. And typhoid is still found all over the world. It's still prevalent down in South America because of poor sewage conditions. Typhoid fever used to kill people by the hundreds in Britain. And it was the first study in epidemiology where they actually finally diagnosed the disease due to contaminated water that was being provided for by the city. Okay? And what the British did was they put in an internal sewer service that's still present today. And once they did that, typhoid went away completely. And so it is related to bad sewage management. Shigellosis is another one that causes diarrhea and dysentery. It's usually found in shellfish. If you like, your not clams, but the oysters, and you like the raw oysters, if Shigella is part of that environment, you can become easily infected by this stuff. I'm more concerned about when I don't eat oysters because of it. It's hepatitis. We saw a big spike of hepatitis one time in our area. Literally 15 people came in down with hepatitis C and from infected oysters. Somebody had decided to sell people beds that were too close to the sewage system, and the people got hepatitis C from it. Very careful with this stuff. It's nasty. So whatever. Some people like oysters. I won't touch this stuff. Sorry. Unless it's cooked, fried, killed, and stomped. Okay, maybe that. But again, Vibrio cholera. Again, you can see this is the actual sewage system. This is called an open sewage system. It's a lot of times found in Central and South America, in certain portions of the city. These are the areas where squatters are at. They just don't. They don't have their own sewage system, and it's just the way it works. People just throw their feces out into the water, and it flows out with it. Okay. Of course, kids come around. What do they want to do? They want to play in the water. Okay. So they get cholera. So it's pretty nasty. They get massive diarrhea. Usually don't do very well. Gram-negative infections such as Pseudomonas. Pseudomonas is, you can see the green right here. That's what I was talking about before. If you put your nose to it, it would smell more like dough. Okay, so the person takes off their shoe and it smells like dough, and they got green nails. Yeah, they got Pseudomonas. Okay, a lot of times you'll see this in the hospital because it's endemic to the sewage pipes. and into the pipes that we have inside the hospital. Why is that? Pseudomonas lives in wet environments. That's why it likes to be in shoes. Okay, because when you sweat, you make a perfect environment for the Pseudomonas. So why would it be found in pipes in the hospitals? Okay, have you ever taken apart the actual drain underneath? There's a little U at the bottom of it. Okay, that's if you drop your ring or something like that, it goes to the bottom there and you don't lose it. Okay, but also the reason the U is also for is it forms a water trap, so you don't get any sewage gas coming back through it. The problem with it is now you have a normal little pond that sits there at the bottom of that pipe. So as a consequence, if your bacteria likes water, it's going to be very happy living there. And when you're washing your hands and you have Pseudomonas on your hands, it's being deposited in there and it's staying there permanently. And it's very, very happy. And you're feeding it nice little skin particles all the time, so that bacteria lives there. And of course, if you put your hand at the bottom of that drain and after you wash your hands, now you've got Pseudomonas back on it. So that's why you're told not to put your hands on the bottom of the sink. If you've never been told that, that's why you don't do that. Okay? Pseudomonas can cause very severe problems. You can see all the green effects, and then it's very difficult to treat because at that point, guess what happens to the blood supply? Very limited, so you can't get rid of it. These people, the best thing to do is prevent from getting to that point. A lot of times if you get this, guess what you have to do? Amputate the leg. That's the only thing that saves them. Okay. Then you get into the really nasty ones. Okay, you have the spore-forming anaerobes. These are things that don't want to have oxygen. They're not happy. Things like gram-positive Clostridium. Clostridium perfringens is what we call gas gangrene. It causes mild necrosis, production of CO2 and halide gas, and it's found in food poisoning. If you ever see a can that's bubbling, you see the can is actually the metal's bubbled up. Don't touch it. It's most likely Clostridium that's in there, and don't open it because all that bacteria will then come out at you. And not that it's going to be a problem unless you have your hands on it, but just stay away from the kind of stuff like that. I've seen people open the cans and of course they get cut. And now they got big problems in their hands. Gas gangrene is very fast. It takes a few hours sometimes. I've seen it ascend somebody's leg. By the time you call the surgeon, it went from the knee to the thigh, and by the time the surgeon put the person in the OR, it's up into the hip. By that point, it's lethal. You can't do anything. It's up in the abdominal muscles and game's over. The way you know that you have somebody with C. perfringens is that when you bovie off the leg and you see the muscle is still contracting, then it's viable. But if you have enough infection, the muscle will literally necrose. And when you put the bovie to it, the muscle won't contract. That means you've got to keep cutting till you get rid of it. Okay? You've got to be really aggressive with stuff. You cannot let it sit. The Civil War doctors knew this so well that they amputated everybody's leg just to prevent this from happening. Okay? Did they overdo it? Yeah, but their survival rates were better than the other wars where they didn't do it. So it's a big problem, to say the least, still today. Then you have Clostridium species like tetani. This is what it's called opisthotonus. Okay? This person's head's here. Okay? What they're doing is they're doing this. Okay? There's so much spasm that these people, they get severe tetany. The treatment is, this is actually in India, is endemic to having tetanus. We have it here as well in anything, but the way they treat it in India is they give high doses of Valium to these individuals, and it stops the spasms. You've got to be careful with it, of course, that there's no reason that people should get Clostridium tetani here in this country with the actual vaccines that we have. We should give that every time somebody's got a cut skin for that reason. Okay? You see this happen. I had a kid do this, and tetany is not benign. Okay? It doesn't just go away. You cause damage. It's permanent. We had one kid that had this because his mom refused to have the tetanus shot because she was worried about causing some kind of mental problem from the vaccine. So she refused. And the doctor that was taking care of the kids said, okay, all right, instead of saying, you know what, pick up the phone, call somebody, kid came back in with this and actually died. So tetanus can kill you. Okay? Botulinum is another, it's a food poisoning. It's a neurotoxin that prevents the presynaptic release of acetylcholine. It causes paralysis as a consequence. We use this very often now as Botox. Okay? Botox is not benign. Okay? A lot of people are now having what's called Botox parties. These are non-medical personnel that are injecting people. You'd be amazed how crazy it's become. Okay? 1,300 deaths have already been diagnosed as caused from Botox injections in people, okay, in this country. Okay? And it's still, being done kind of out of control. So just be careful. You decide to get Botox, get somebody that's actually that's an expert. They had 2 people last year that were actually experts, plastic surgeons, that decided to inject themselves. They didn't realize it was the activated form, and they both died of asphyxiation as they became paralyzed. They called 911, but by the time 911 got there, the paramedics got there, they were both dead. So this stuff is not benign, so be careful. The other thing that you carry about Botox injections and anesthesia is that a lot of times these people in Naples, if you look at their face, they look like they have no expression at all. That's the first tip off, okay? And you ask them to furrow their top. They can't furrow their forehead at all because they have so much injections up here. What happens if you try to use your nerve stimulator on here to see if you have a train of 4? You get nothing. So you go like, man, I don't have to give anything to this individual, right? And then the person moves when the surgeon cuts. Okay? So it's kind of a nightmare. Okay? So be careful with it. Just make sure that the person doesn't have Botox ahead of time. If you do, always do it in the arm. That's what you train it for. That nobody puts Botox in the person's forearm. So at least you're not supposed to. Then you have syphilis. Syphilis can go into 3 phases. The primary phase is a canker sore, pretty obvious to most people. Okay, it causes it's supposedly non-painful, is what I heard. So I don't know. It seems painful to me, but they say it's non-painful. If you get to the next stage, you get mucocutaneous lesions, splenomegaly, and lymphadenopathy. And these people are highly infectious to you. Okay, so you got to be careful with them. Then you get stage 3, it goes to the central nervous system, and it begins to destroy the brain. Okay. You also attacks the aorta, this is a picture of the aorta. It causes aortic dilation and usually aortic insufficiency and the aortic rupture. Okay. The most common cause of AI post-World War II was from syphilis, and it was common. Spirochetes that you also see in things like Lyme's disease. Lyme's disease, of course, is what's called tiered tick disease. It's a multi-system infection that's attacked by these little spirochetes, okay, called Borrelia burgdorferi, sorry. And it causes erythema chronica migrans. It causes arthritis and neuritis, encephalitis, and it may actually cause an AV block in some individuals. The way you get infected from this is usually from a deer bite, okay, from what's called a tick. Sorry, a deer tick bite, not a deer bite. Oh my goodness, okay. Interesting deer, All right, so you see a lot of this in the Northeast. So if you're going up in there camping and stuff, you always have to worry about these ticks that can cause this disease from the actual, they're infected and causes problems. The way you see it is they get this kind of lesion that kind of jumps out at you, and the lesion tends to get bigger with time, so it tends to be something that's helpful to diagnose. It's it's responsive to antibiotics usually when they're appropriately given. You may also have things like Mycobacterium. Mycobacterium are a little bit different. I'm not going to go into all the specifics about it because I think it's a little bit too much. But things like you have to worry about mycobacteria is Mycobacterium tuberculosum. Okay? It's an obligate aerobe. Okay? So this is actually one that requires high levels of oxygen. Okay? And the highest level of oxygen is in the apex of your lung. And as a consequence, that's where you see it. Okay? The treatment in the old days, and you still see it every once in a while, is that people would ablate the top portion of the lung. They would actually put in trocars and destroy the upper portion of the lung, and then that would collapse, scar down, and the person would stop having the TB. Pretty interesting treatment, not to say radical. Nowadays we have multiple antibiotics. The problem with Mycobacterium tuberculosum is that it's becoming highly resistant. And there's some of these bacteria that are coming from Mexico that are so resistant that nothing treats them. And that's a concern because we're taking care of a lot of people that are coming over the border that are not being properly managed overseas. And as a consequence, they're bringing in TB into our country. Okay? 90% are asymptomatic, unfortunately. So PPD test is very important to pick up the disease. Okay? There's high incidence of concomitant HIV as well that we're finding. So in these, it could be immunosuppression. That may also be reason for the activation or disease process. We think that the normal immune system will most of the time fight off this disease, but it really becomes a problem in somebody who's immunocompromised. What's the other name of this disease in the old days? What was it called in all the textbooks and all the famous novels? Consumption. Okay, consumption. What was it called in the past? The reason it's called consumption is because it literally will consume the body. The person's body mass begins to fall. The person becomes very frail and thin, and they're more likely to develop other secondary infections, which ends up killing them. You may also get another form of mycobacterium, which is endemic to Louisiana, okay, which is leprosy. Okay, why in Louisiana? What particular animal has Hansen's disease, which is where the leprosy comes from? You see them all over the road because people keep hitting them. Armadillos. Armadillos carry Hansen's disease. So should you eat armadillo? No. Okay. Should you play with armadillos? No. Okay. So when you see the kids, when you see a run over an armadillo, don't go over and kick it. Just sort of just leave it alone. Okay. Because they might carry leprosy and you don't want to get it on you. Okay. This is what happens to you if you're not treated for leprosy. You can see it begins to causing the digits to be lost. Leprosy used to be very common in the old world, in Europe as well. It's very much treatable now, so you don't see it very often anymore. It's treated with antibiotics, of course. Sometimes it can be a little difficult to treat, but most of the time it's responsive. Then you have what's called fungal infections, or called mycotic infections, and these include the molds and yeast. Okay. This is nasty stuff, to say the least. Okay. You get blastomyces dermatitis is a pulmonary involvement, which is fever, cough, and you also get orthopedic involvement. You can get also blastomycosis dermatitis. You can see what happens to the person's face. Okay. These are nasty, nasty diseases. The only way to get rid of this stuff is you have to remove it surgically. And of course, in somebody's face, can you really do that? The answer is no. So instead, you try to treat it with medications, which a lot of times just don't work. So you end up having somebody with severe heart scarification and injury like this, secondary diseases. A lot of times, these people have associated diabetes or some kind of immunosuppression that's causing this issue. Then you have coccidioides, which is you get pulmonary and meningitis signs. You can see other things that you see. It begins to infect the skin. It breaks down the skin. Fungal infections, thank goodness, are rare because the body tends to fight them very effectively. But usually you'll see it in an immunocompromised individual, and that causes these kind of issues. Histoplasmosis tends to be a pulmonary infection, and usually you'll pick it up on lung biopsy. You can see the actual fungus in here, what it actually looks like. It's got hyphae and septi. Then you have things like Mycoplasma pneumoniae, okay, which is atypical acquired pneumonia. This is one of the most common forms of infections that people get. These are called walking pneumonia. These people a lot of times will just present as chronic cough. They're not feeling well. They think they just have, the flu, but it's actually mycoplasma of pneumoniae. Then you have rickettsial diseases like Rocky Mountain spotted fever, and you get rashes, and you may go into thrombocytopenic purpura as well. The people have microhemorrhaging all over their skin. So this is a rickettsial disease caused by the tick. You also have Q fever. These are all rare diseases we don't see here very much. It's airborne from livestock. So if you're living in the West, where you have a lot of livestock and you're around them, you may actually get these kind of more of diseases. But here in Florida, you don't see it very much unless the person is actually working in the fields. Who has the highest amount of cows in their state? Florida. So believe it or not. Okay? You think Texas, everybody says Texas, but they don't. Actually, we have more cows here than they do. But we don't see very much Q fever in them as much as they do out in the West. So, thank goodness. Then we'll talk about viruses real quick. Viruses are incomplete organisms that can't really replicate by themselves. Okay? For them to replicate, they must infect a eukaryote, usually. Not a bacteria, usually a eukaryote. Well, using a bacteria at times, but it can infect a multicellular organism, and then it binds to the interior portion of the DNA or the RNA and steals the mechanism of that cell to produce itself again. That cell becomes basically the factory for that virus. Okay? And then when it releases the virus, many times that cell will auto-lyse and destroy itself in the process. And then the virus goes from there and attack other cells in the body. So it continues to propagate. Some viral infections can become controlled very quickly, and usually the viral infection then stops. If the infection cannot be stopped, okay, it will go to either a fulminant phase, which means that it attacks all the cells so fast that it destroys them all and kills the individual. Things like fulminant hepatitis, that's what it actually is. It's actually an attack of the whole liver so aggressively that it kills the liver. And it may be also immune regulated, where the immune system fights it and kills the cells in the process. Now, in the process of producing these viral these viral virions, it also produces receptors on the cell surface that identifies that cell as being a now infected cell. So the body has a way of identifying what cell is infected. And when we talk about immunology at the end of today's lectures, we'll go back and review this. Viruses are many. The influenza viruses, of course, are things that cause pneumonia with impaired mucociliary transport. So influenza virus is something we have to constantly fight every year. The bad thing about influenza is it's shedding or changing its outer surface all the time, so the body is basically being exposed to a new virus every year. So it's difficult to treat. Rhinoviruses are also cause common cold. There's almost 150 to 200 different kinds of rhinoviruses, so it's actually very difficult for your body to completely get rid of all the actual common cold. The adenoviruses, you got respiratory syncytial virus, parainfluenza virus, and HPV. The adenovirus, respiratory syncytial virus, and parainfluenza virus are very common pediatric diseases. If you've never worked in a pediatric unit, when you walk into a pediatric unit, you're sick for 3 months. Okay? So you can always tell the resident or a new medical student that's working in pediatrics, because they're the guys with a runny nose, feeling sick, looking like hell. Okay? When they're finished with their 3-month rotation, they all of a sudden get miraculously better. And then when they go back to work in the pediatric area later on, guess what? Nothing happens. They become their immune system upregulates at that point and protects them from it. Okay, which is a good thing. Okay, so if you've worked in pediatrics, good, you won't get sick. Okay, HPV is becoming a huge problem. There's many different kinds of HPV viruses. But one of the problems is that they cause cancer over time. They begin to break down the DNA so it doesn't work properly, and as a consequence, it's more prevalent for developing cervical, uterine cancer. There's also been now associated increases risk of developing penile cancer as well in men, especially in foreskins. So all these diseases are now, we're even considering doing vaccination on men. Women are now being vaccinated for HPV. But unfortunately, it doesn't cover all the HPV viruses. So if you have a young lady that you're concerned about, at this age, all my girls got HPV virus, the vaccine, because you just don't want to get exposure to this virus and then get infected and then get the cancer later down the road. But males have not been normally treated with this vaccine, but now it's becoming recommended because they're also having signs of them getting other problems as well. Herpetic infections, the herpes simplex virus, there's two kinds. The type 1 is oral. The risk of ocular and central nervous system spread. You can see that the lesions are inside and they get labialis as well. Herpetic whitlow happens a lot of times to anesthesia personnel because they put their fingers in people's mouths, okay, and they break their skin, and that's where they get herpetic type 1 infections of their skin. Very, very painful, extremely painful. I've seen people have it, and it's really, really uncomfortable for them. And it's just because they weren't wearing gloves when they put it in, or even they're wearing gloves and the glove was penetrated, and as a consequence, they got infected with it. Okay, so what I'd recommend, if you have anybody that you know has herpes kind of viruses in their mouth, get surgical gloves and put them on. Okay, you need that protection. Okay, it's worth the extra cost for the glove at that point. Okay, my personal thing is I don't put my hands in anybody's mouth. Okay, I just don't do it. Okay, so I open the mouth in a different way with my blade. Okay, but that's an advanced technique. It might take you a little time to get used to that. You're also taught always to be able to scissor somebody because you may not be able to work it with the blade, then you have to learn how to open the mouth properly. So you still have to learn how to do that anyways. Okay, but then you can learn the more advanced technique of just opening the mouth with a blade and not causing any problems. Okay. Herpetic infections, type 2 or genital herpes. This is what you see. You see lesions on the skin. Okay. These are also very painful they're itching. Causes problems. As a consequence, when you itch this area, of course, you can spread the disease, so it's a concern. The one that I had when I was 28 was varicella zoster, chicken pox. Not fun to have it when you're 28. We didn't have the chicken pox vaccine like you guys have now. You definitely should get it if you've never been exposed to chicken pox. My kids have all been exposed to chicken pox when they were young kids. Here, get it, because that way you don't get it as an adult. So you definitely get a typical lesion from this. What happens in adults is that the fever gets very, very high, 104, 105 fever. You can actually fry your brain from it, so it's not good. Sometimes it'll actually go to your brain and cause a terminal event, so you've got to be careful with it as an adult. And usually in kids, it's not a big deal. These kids are just kids sick for maybe 2 or 3 days, and then they get over it pretty quick. So, but don't think chickenpox is not completely benign. And any kid who's immunocompromised or has a slight, problem with their immune system, chickenpox can actually go neurologically and cause problems in them as well. You have other things like a cytomegalovirus and Epstein-Barr virus. These kind of herpetic infections all end up forming some forms of cancer down the road. EBV virus has been associated with things like bone marrow problems, lymphomas and things like that. So all these viruses that go into the cell and begin to play with the DNA sometimes screw up the mechanism and start causing other additional problems later down the road. EBV virus is associated with infectious mononucleosis, of course. You get eventually cancer of the nasopharyngeal cancers, Burkitt's lymphoma. If you have AIDS, a lot of times you get other secondary diseases called hairy leukoplakia, which is what this is. Okay? You get the interstitial pneumonitis in these individuals. and you may also develop what's called non-Hodgkin's lymphoma. The HIV virus was something that I'm glad we had this problem in the 1980s, because we had enough technology to figure out what the problem was fairly quickly. But being an individual that came through in my training right when the HIV epidemic was at its peak, when we first got into medical school, the first thing they sat down with us and said, you guys have a choice on your first day. We realize that you have HIV as a disease that we don't know what's causing it, but it may kill you if you're a doctor. Are you willing to stay in the profession? Because otherwise we're not going to train you. That was our first discussion. And the people that stayed said, okay, we'll stay. That's what we're here anyway. So, I mean, we're here to figure out what the hell this stuff is. So that was our introduction to medical school. It was rather interesting. At that point, we didn't know what was causing it. We knew it was a virus, but we didn't know what was exactly the virus. And we knew that it was highly infectious, but we didn't know exactly the complete route. Everybody was severely panicked at that point. And what we ended up doing was the number of glove orders skyrocketed in the United States. Okay, the actual numbers of amount of boxes of latex gloves that were used went up by 100-fold or 1,000-fold %. Okay, so one of the things that ended up happening is, and we'll talk about it in sensitivity reactions, is that the latex builders did not do a good job. They tried, but they just couldn't process the stuff fast enough. Anyways, HIV is basically a retrovirus. It basically infects an individual by multiple routes. It has to be a skin penetration that has to get in that way. So it's actually a breakdown of the skin. So as long as you don't have breakdown of the skin, you tend to be okay. The also things that will allow things will come in is the lining inside your GI tract. If it's injured, is more likely to become infected as well. Okay, so HIV, we do have different kinds. We know that the first HIV that came out was very lethal. Over time, the HIV that we have now is less lethal than it was back in the early 80s. Okay, so the ones that tend to be more selective of killing the individuals very quickly sort of died out that line, and we are left with more of a disease process that's more indolent. Okay, so it becomes, unfortunately, then it helps bypassing it around. What HIV really likes is it doesn't want to kill the organism. It wants to stay chronically infected, because then it can pass itself on to the next person. Okay, so if you have a disease that's very fulminant, it tends to terminate very quickly because it kills all the host. It's sad for that host, but it's good for the rest of the population, because now you're left with not a chronic disease. Versus this now has become a chronic disease which is full of all sorts of social and political problems with it. And I can tell you it was very frustrating as being a medical personnel. We couldn't isolate individuals with this, where you're always taught proper technique of any kind of infectious disease is isolate individuals immediately and try to stop the disease first. But literally that was deemed to be non-political, and these people unfortunately were left around to continue propagating this disease. Okay? And the consequence, you got your problem that you have now. What you see with HIV is that it infects, and it's an RNA virus. Okay? The RNA then using the actual enzyme called reverse transcriptase provides a DNA fragment once inside the cell, and that DNA fragment then embeds itself inside the person's DNA. And then it basically begins to produce its own virus at that point. Okay? What's interesting about the actual HIV is that the actual outer layer constantly is changing. And that's a real problem for us, because we can't form a vaccine to it. It's almost like an influenza on steroids. Okay? Influenza does the same kind of thing. It constantly changes its outer surface. So you can't really form a vaccination to get rid of it. Okay? And they're still trying, but it's going to be difficult because they are constantly changing their outer coat. AIDS, eventually, what happens is the human immunodeficiency virus, which is called HIV, is that it begins to attack the white cells, eventually killing them. And actually, the T helper cells can become significantly suppressed. and as a consequence, these people have life-threatening infections that normally would not be an issue. Okay? So you get Kaposi's sarcoma, you get multiple opportunistic infections, funguses, molds, bacteria, everything we were talking about before, all these people have that. And that's how we initially knew it was an immunodeficiency problem, because they started acting like organ transplant patients. Okay? Transmission, of course, is sexual contact, bloodborne, especially through pre-used IV drug abuse. Post-exposure AZT as well. Decreased rate of seroconversion has been noted after these people have been exposed to it. So, the new treatment is, if you've been stuck by somebody like this, is to give you AZT. I can tell you, you're not going to feel very good with AZT, so most people are kind of leery of it unless you know that it's definitely a positive contact that you're having. My personal thing is make sure that you're always protected, always keep away sharp needles away from you. Be cognizant that there's many systems in place right now that you should not have any sharp needles playing with them at all. The only ones you have are the IVs, and those are retractable in most centers now. So you should try to use all those devices to try to protect yourself. You should never recap, okay, any needle. That's bad form. All the needles now have systems where you can actually cover the needle after it's used, and you got to learn how to use them. If you don't learn how to use them, it doesn't protect you. So please do that to protect yourself. Okay? Getting AIDS is not something you want to get. This is what Kaposi's sarcoma looks like. Okay, you can see it's this erythematous lesion all over the body. Treatment is complicated, to say the least. They use antiretrovirals, and then you got to also treat the actual opportunistic infections. I'm not going to go into all the different drugs. Just know that there's a huge. They actually perfected it pretty much down to keeping people with HIV alive for a very long period of time, and it seemed to do pretty well. But there's a whole regimen which is above my level of training, and I'm not going to even discuss it. So, prevention is basically universal precautions. Make sure you protect yourself. If you do get exposure to bodily fluids, it's recommended for infected, high-risk needle sticks. And it's optional for other exposures such as intact skin or mucous membranes. It's not recommended for exposure to urine, which is still considered sterile, this virus. The next disease is myocarditis, which is you can have many different kinds of bacterial or protozoal infections. Viral-wise, you get adenoviruses that can attack your heart. It can cause a significant cardiomyopathy. You can have Chagas disease, which is a parasitic, protozoal disease, which is called Trypanosome cruzi, which is what this is right here. It's got a flagellated organism that goes in through your GI tract and eventually embeds itself in the heart and starts causing cardiomyopathies. You may also have drug-induced myocarditis, which we're not going to go into that. We'll just keep skipping that. Nosocomial infections, which are surgical infections, could be due to IV access, urinary catheters, all these things that you got to make sure that you avoid. Okay, you don't want to induce disease in individuals as much as possible. Anesthesia equipment is pretty much free of viruses or bacteria or TB. The actual soda lime is so caustic that it kills everything in it, so it kind of protects individuals. So that's kind of good. So you don't have to worry about it once you change out the circuits. In the old days, the circuits weren't even changed out; they were just cleaned in between cases. That's it. They'd use the same one over and over again. Nobody's ever been able to diagnose somebody with getting an infection from those tubings, even then. So, the cold air environment, high oxygen, rich oxygen that you're providing kills most organisms. But what we do still is we replace all the circuits, and we try to do the best we can to prevent any kind of source of infection to the individual. I personally think that most people are sloppy initially when they're learning. When they take the blade and they put it in the person's mouth, I'd rather be bit by a dog than by a human. Dogs' bites are less dirty than the humans. And then we take the blade out and we lay it on top of stuff. Or you put your finger in their mouth and you're squeezing the bag and you're playing with the machine and you're spreading bacteria everywhere. Okay? What we finally did one day, just to prove the point, okay, we took a dummy and put blue dye on them, okay, that you couldn't see. And then we let people just do the normal intubation technique, and then we let them touch everything. They normally do it without telling them to take their gloves off and stuff. And then we took the fluorescent lamp, showed it to them, and it was everywhere. Okay? If you're not careful, when you put your hands in a person's mouth, you can't just go back to your equipment and start touching everything. You've got to take your gloves off. Okay? That's why I'm not a real fan about putting my hands in anybody's mouth, because I just put my blade in and then put the tube in, and I don't put anything in that person's mouth. So it can't take the bacteria there and move it elsewhere. Okay? So just make sure that you keep your equipment clean at all times. Sepsis and septic shock is, of course, a complex mechanism. It includes activation of things like the host response to the cytokine and the arachidonic acid pathway. We'll talk about this in part of the immune system response here a little bit later, so I'm going to skip through some of this. Eventually, you get what's called mast cell and basophil degradation in some of these diseases, and you can see how much stuff that can be released by these things: leukotrienes, prostaglandin cytokines. I don't expect you to memorize this, so I don't have to worry about this for the test. I just want you to know that your body releases a lot of these compounds into your bloodstream, and that can induce the septic-like syndrome that you see. What you end up having is gram-positive and gram-negatives will release different things, but they end up having the final common pathway of these pro-inflammatory cytokines being released, and which ends up causing the symptoms that you see. So you can't just say, well, because it's a gram-positive, you get a specific kind of reaction compared to gram-negatives. No, the answer is once you activate the system, you cause a whole host of effects that cause the septic kind of syndrome that you see. And it eventually leads to multi-organ dysfunction, which is what shows you at the bottom. And if you don't treat it appropriately, identify the source and treat it, you end up having a dead patient. Organ dysfunction includes pulmonary-wise, cardiovascular, everything pretty much in the body, including renal failure. So you also get DIC and from arachidonic acid metabolites as well, and coagulopathy develops in these individuals. Again, you get DIC from this. Again, if you want to look into this, this is something that if you're interested in ICU work or interested in taking care of patients that are coming in from the ICU, you also have to keep this in the back of your mind about this kind of pathway. And again, it's not one of the things that I expect you to memorize too much. One of the things that I do expect you to understand is treatment and aesthetic considerations. A lot of these people are cardiovascularly empty in volume. Okay, even though they've been given lots of fluids, the capillaries are leaking so much that intravascular, they're depleted. These people may actually need blood to keep it inside intravascular space. So always volume should be in the back of your mind, and I would recommend you put in monitors to monitor for that, so PA catheters or indicators of CPP, to at least understand how much volume you have in that individual. You may also, of course, have to treat them with pressors or inotropes. Patients have been found to have increased survival rates when they were putting on levofed at low doses to maintain some form of vascular tone in these individuals, because too much fluid is not going to help you either. Eventually, if you give too much fluid, it leaks out into the lung, and you get, as a consequence, inadequate oxygenation because you start getting diffusion impairment. Okay? Renal-wise, if you don't give enough intravascular volume, of course, you don't get enough GFR. Kidney eventually shuts down, you get ATN in these individuals. Most of the time, the liver keeps working until the end process. If you see hepatic failure, usually that's an end process where now the ventricles begin to fail because the cardiovascular system basically is not pumping enough volume around. Coagulopathy is fairly common. In central nervous system, it's a very early sign of septic shock is confusion. You may also have effective endocarditis, things like people at high risk or people with prosthetic valves. This is a nice picture showing you the actual valve itself is completely eaten away by this. So patients that have a prior history of endocarditis, patients that have cyanotic heart disease where they have VSDs or ASDs are more prone to high turbulence problems. And as a consequence, you have issues with that as well. Intermediate risk are things like mitral valve prolapse with regurgitation. Sometimes even those people are not considered even for treatment. So depends on which book you read. Most people are now just treated for high risk, which are these. Low risk are mitral valve prolapse without regurgitation, minimal regurg. ASDs, coronary artery pacemakers, all those greater than 6 months are really considered low risk. What we do is for dental procedures, anything that operates in your mouth, there's increased risk for infective endocarditis. Okay, so things like cholecystectomy, urinary tract surgery sometimes will have an increased risk of infective endocarditis if the person has stones. So we treat them with pre-antibiotics before that. Almost everybody's treated with antibiotics anyways right now for any kind of procedure, but to prevent infective endocarditis, you really have to do these kind of things. Procedure not requiring antibiotic prophylaxis is non-bleeding dental, which is almost never. PE tubes, intubation, flexible bronchoscopy, so upper airway examinations usually don't require problems. D&C, in the absence of infection, vaginal delivery, and laparoscopies, tubal ligation vasectomies are all considered not at risk. Antibiotics include penicillin and streptomycin. That's where I think you need to know that. You need to know what you have to give these people. We tend to give penicillins and streptomycin. If we're doing hepatobiliary or GI surgery, we actually add more potent agents sometimes besides the penicillin, which is ampicillin, is we add vancomycin and gentamicin for the gram-negatives. And cardiac surgery, penicillin-resistant penicillins or cephalosporins are very often used. CNS infections, you got meningitis or epidural abscesses. Meningitis is the more common due to influenza, strep pneumoniae, Neisseria, meningitis, especially in younger people. They get fever, headache, vomiting, nuclear rigidity. Something you always have to worry about, especially if your kid's going to college. That's where you see spikes in Neisseria and meningitis, and usually in young people that are in close proximity to each other. Epidural, and the other places in the Army and the military. Epidural abscesses, thank goodness, is rare, okay, but sometimes most epidural abscesses are due to your own nasal mucosa. And that means you're breathing into the wound. Okay, so if you're not wearing a mask, I'm going to be very upset with you. If you see people putting epidurals without a mask on, they're morons. Okay, they're going to hurt somebody. Okay, so make sure that you wear a mask at all times. Okay. It's bad to get an epidural abscess because it's difficult to treat in the sense it's surgical. You have to actually do a laminectomy and drain it. And if you don't get to it quickly, it can form a compression problem, and the person is permanently neurologically damaged. Not what you want, to say the least. Spontaneous epidural abscesses do occur because of bacterial seeding that occurs in individuals. Usually it's gram-negative in that situation because gram-negatives tend to be more sticky in those kind of situations. You can also get brain abscesses. Okay, this is a bad one. This is a brain abscess. Okay, usually it's followed by necrosis of that area, and then you get the brain abscess forms after that. So it's usually from an infarct, from an embolic phenomena that occurs first. Bacterial upper respiratory tract infections as well. You get sinusitis. Can be from NG tubes, nasotracheal tubes. That's why it's usually not recommended to keep anybody intubated nasally more than 72 hours. Because almost everybody develops a sinusitis infection. So NG tubes really should be left in the mouth if you're going to think that the person's going to be chronically intubated for prolonged periods of time. That's the first place we always would look for high fevers after 72 hours was usually in the sinuses, and it ended up being positive almost every time. Otitis media, you want to avoid nitrous oxide in these individuals as you can cause compression. What we actually use is use nitrous oxide to help the surgeon for drainage and to put in their little tympanoplasties. Not tympanoplasties, but the actual tubes. Because what happens when you give nitrous oxide is it goes into the middle ear and it distends it and pushes it apart. So as long as the surgeon is going in there to perforate it and put the tube in, it doesn't matter if you're using nitrous oxide. But if you have somebody who's got otitis media and you're not going to treat it, the lining in here, which is the eustachian tube, a lot of times is inflamed and not allowing air to come out. And these people come out with severe hearing disorders and they can have a lot of pain. Eventually the nitrous oxide does get reabsorbed, but why put the person through it if you don't need to? Pharyngitis is, again, things like this. You can see the pharynx gets infected. You get peritonsillar abscesses. Let me tell you a story about this, okay? And you got to listen to me because it's not part of the books, okay? You see this abscess here? This is what's called a peritonsillar abscess. These people can obstruct completely and where they can't get any air. Now, a lot of people don't read, or the books don't say it well enough, but they'll tell you to go ahead and intubate these individuals. And when you touch it with the blade, that's what happens. It bursts. Okay, now you got pus all over the airway, and guess where all that pus goes? Right down the lungs. Okay? So, the way I was taught to do it, and I've done it twice in my career, is you put a spinal needle onto a 50 cc syringe, you penetrate the tonsillar abscess, and you draw it back, and you take the pus out. Okay? The first time I did that with an ENT surgeon, he looked at me, I was crazy, and as soon as I did it, the person felt better, and actually we canceled the case. Okay? So, and then you can treat it with antibiotics. The reason I learned it from was with a guy who was an old-timer, and I was working at a VA hospital by myself, and this person was completely occluding, and I said, well, you need to come in here and do a trach. He said, nah, just do a needle. And I said, what? I have never done that. I said, well, you just told me how to do it, and just said, do it. It's like, I had no choice. So pulled out almost 70 cc's out of this guy's mouth, the first one that I did. So it's very effectively resolves the problem very quickly. Okay? If you tried, and I've seen people fail at doing this where they actually intubate these individuals and it ruptures on intubation. And that's really, really bad. The airway is unprotected at that point, and then you got big problems in your hands. Okay? Epiglottitis can actually go down, all the way down into the epiglottis, and you get what's called the thumb sign, which is right here. This is what actually George Washington died of. Okay? He died of epiglottitis, and he actually succumbed to it. Okay? So this is a bad H influenza bacterial infection that attacks the upper airway. There's not much you can do about it except get that person intubated as quickly as possible and get them on IV antibiotics. Bacterial pneumonias is what they look like here. Okay, I'm not going to go through this pretty quick. Bronchitis, we already talked about. Lung abscesses are usually due from ethanol abuse because the person's vomiting into their lungs. Aspiration pneumonitis is not a joke. I know you've talked about it enough. You know about Mendelssohn's syndrome. Does anybody have any questions about Mendelssohn's at this point? I mean, we've hammered you enough on that. I think you should be able to know that. Intra-abdominal infections, anybody who has peritonitis is considered to have acute abdomen and should be treated as such. So all these people are high risk for aspiration on induction. So immunosuppressed patients could be on chemo, AIDS, or steroids, high-dose steroids also to be concerned. And I think that's all of it for today. Okay.